Hello, my fellow physicians, my colleagues, and students who are trying to pass the AMC Step 1. So, I'm back from my sabbatical, and that is the reason a lot of the videos did not get uploaded for a very long time. But, anywho, let's just jump right back to our videos, and we'll be continuing from where we left off. Today, we'll be discussing chapter 12, which is one of the most important chapters that covers psychiatry. Now, if you guys want these notes or any of the related topics, the therapeutic guidelines, or any information, how do you do your AMC, you guys can join the Telegram group and the WhatsApp group that has been linked in the description down below. Now, in today's topic, we'll be discussing depression, bipolar disorders, schizophrenia, anxiety, BPD, postpartum moods, defense mechanisms, and gender incongruence. In the past few months, I've seen gender incongruence a lot. I've seen schizophrenia a lot. I've seen bipolar BPD, and depression a lot. And one of the questions that they like to ask a lot is the difference between depression and anxiety, and difference between schizophrenia form, schizotypical, and different forms of those disorders. All right, so we'll be going over those briefly. Right, so let's just start with MDD, which is major depressive disorder. So, according to DSM-5, the criteria is that for a person to be diagnosed with MDD, they should have more than or equal to 5 symptoms for more than 2 weeks. Now, remember, the timelines are very important because they'll give you patients and tell you that they had these symptoms for maybe 2 weeks, right, or less than let's say they'll say 10 days, right? So that's less than 2 weeks. So you can't diagnose them with MDD at that point, right? And they should include at least one or more core features. So those core features would be first would be depressed mood or anhedonia. Now, what is anhedonia? Anhedonia means that they don't feel any desire or any happiness, any sadness from the work or whatever their day-to-day life is. All right. Now, the additional symptoms to make a complete 5. So this will be 1. It would be sleep disturbances, appetite or weight changes, fatigue, concentration difficulty, psychomotor changes, worthlessness or guilt, suicide ideation. Now, this suicide ideation is one of the most important things that you ask a patient when they come to you, because those are the things that they are going to directly affect the lifestyle of the life of the patient, not the lifestyle, sorry. So AMC could ask that this patient comes with depressive episode symptoms, so what is the next thing that you ask them? You should ask them about suicidal ideation. All right, now moving on to another part, that the severity of it. So in mild, we have a total of 5 symptoms with minimal impairment. Now, minimal impairment would mean that there's impairment of their day-to-day life and how they're doing their office work or any of the work associated with the lifestyle that they have, and especially having sleep disturbances as well. So one of the additional symptoms is sleep disturbance. All right, now moderate or severe would be 7 to 9 marked impairment, and they may have psychotic features as well. All right, now coming up to the treatment. Now, the treatment would be antidepressants. SSRIs are always first line, with sertraline, escitalopram, and fluoxetine. They are the ones that are given most commonly. All right. Now, these are first line for both depression and anxiety, and their onset usually takes 2 to 4 weeks. So, if a patient comes in less than that time and they say that I don't see any difference, you tell them, okay, continue taking the medicine for another week. All right. They will have sexual dysfunction, GI upset, hyponatremia, especially in the elderly, which is dangerous. So you'll have to find a replacement drug, or you'll have to change their SSRI. Now, this is a very common concept, especially if the person has low libido, or they have gynecomastia, prolactinemia. So you'll have to change their drug from SSRI to, so such as the thing sertraline, you'll have to change it. All right. If you guys want to go into details for this, and the details, they're all in the Telegram group, so you guys are welcome to join those groups as well. Now, SNRIs, they are after SSRIs, right? So venlafaxine is the one that they usually commonly ask for, so that's useful for depression, pain, and anxiety. All right. Now, in venlafaxine, the side effect is that BP is going to rise at high doses, so you have to keep a check for the BP and the dose that the patient is taking. Now, the tricyclic antidepressants, we have amitriptyline. I've not seen a lot of questions about ATCAs, so usually the questions are about these two. Now, the thing that they like to ask about for TCAs is that it is toxic on overdose. All right, so what quantity is there? And it's useful for neuropathic pain, migraines, and prophylaxis. So migraine prophylaxis, we give TCAs sometimes. All right, another drug that's important is ARBs for beta blockers for being given as prophylaxis for migraines. All right. Now, Murtagh, I've not seen a lot of questions about these, but again, it's going to have sedation, weight gain, useful for depression and insomnia, and if the patient has poor appetite. Electroconvulsive therapy. Now, this is the for extreme cases. I've seen one question, and I've seen it in a lot of the exam week recalls as well. It's a mother who thinks its baby is evil. She does not want to feed the baby. She does not want to take care of the baby or herself, and she's endangering both her life and the baby's life. So the most appropriate treatment would be ECT. All right. And especially for severe refractory depression, psychotic depression, high suicide risk, and needing rapid response, and depression in pregnancy. All right. Now, this is an important point, which is serotonin syndrome, and I've seen a lot of questions about these. Not just the to recognize the diagnosis, but what is the treatment for it. All right. Now, if you're preparing for AMC, you have to remember that they will ask about not just what's the diagnosis, but what's the next step in management, or what's the best next step in management for that patient in long term. All right. So in this, we have neuromuscular abnormalities such as clonus, hyperreflexia, tremor, then autonomic instability such as tachycardia, diaphoresis, and fever, then altered mental status, and usually the causes are going to be SSRIs. So if they are taking SSRIs, we discontinue it. But if they come as an emergency, right, and they're in a bad condition, we stabilize them and we give them cyproheptadine. Now, if they are if cyproheptadine is contraindicated, we give them benzodiazepines. All right. All right, so this is one of the core important topics that you need to know as serotonin syndromes. All right. Now, moving on to bipolar disorder, the symptoms for it are going to be less than or equal to 3 symptoms for more than 1 week. All right. Now we have dig fast in this, which is a manic episode, which is distractibility, impulsivity or indiscretion, grandiosity, flight of ideas, activity increased, sleep decreased, and talkativeness. So they basically feel that they're superhuman. All right. Now, the first line of drug for this are going to be, so the group that we use are mood stabilizers for them. So now best is lithium to start off. We have to monitor their serum levels as well as the renal function. Then the toxicity is going to be more than 1.5. In this, they'll have, of course, tremors, ataxia, confusion, and drug interactions include NSAIDs, ACE inhibitors, thiazides, dehydration, and all increase lithium levels in the serum. And obviously, it's teratogenic. Epstein's anomaly, you guys should know what that is. Now, the thing about mood stabilizers is that you should know which of them, especially for all of the drugs. For all of the drugs, the importance is that you should know which can be given in pregnancy and which should be avoided in pregnancy. All right. So we have sodium valproate. We have to monitor LFT, FBE, and drug levels. Then it is highly teratogenic. All right. Avoid in women of childbearing age. Weight gain, and alopecia, and hepatotoxicity is one of the side effects. All right. Lamotrigine, we have to monitor rash because it has a risk of SGS, which is severe side effect. We have to titrate it slowly, and it's better for bipolar type 2 depression, and it has a lower teratogenic risk. All right. Then quintiapine, it is we have to monitor the metabolism. The patient can have we have to avoid it in acute mania in bipolar depression, and we have to look for the side effects while giving a maintenance to those patients. All right. Now, moving on to schizophrenia. Now, schizophrenia, I've not gone over the different types of the different types of disorders that encompass under schizophrenia because they are very short. They're just one line, and I didn't want to include them in the guidebook because you guys can easily find them in the Telegram group as well. It's just one line for each of them. All right. Now, the diagnosis for it is in DSM-5 is more than 2 or 5 symptoms for more than 1 month. Remember this time period, right? Because some of them are for 2 weeks, some of them are for just 1 week, some of them for 10 days. All right. So 5 symptoms, more than 2 or 5 symptoms for more than or equal to 1 month. All right. And the core symptom they should have is delusions or hallucinations and disorganized speech, and a total of it should be for 6 months. All right. So either of these for a few weeks here and there, for a few months here and there, the total should be for 6 months. Sorry. All right. Now, the antipsychotics that we use. So in EPS, we'll have akathisia, which is inner restlessness, dystonia, and dystonia is one of the side effects for it, and you have to treat it with benzodiazepine, IV or IM. Dystonia is one of the side effects which we need to treat with benztropine, IV or IM. Then Parkinsonism, tardive dyskinesia, metabolic syndrome, and QT prolongation. All right, so a lot of the times they'll ask you these side effects in the exam as well. Now moving on to clozapine, this is used in patients who have disease that is treatment resistant, and it's mandatory to check their FBE weekly because clozapine can lead to agranulocytosis in 1 to 3%, and it's a bad side effect, and we need to keep an eye on it. All right, and it's one of the most effective antipsychotics. Now, all of these, the features, the drugs, and everything have been listed in the Telegram group as well, especially in the intensive group. So, if you guys want to go over those, you guys can check out the Telegram group. If you already have a placement letter, just send it to us and we'll add you to the Telegram group. Now, I emphasize on this because those are very high yield points that help me a lot. They helped a lot of my colleagues, my friends a lot to, go and do the exams. All right, now, NMS. In NMS, we'll have fever, rigidity, altered GCS, autonomic instability, and for this is important to stop the antipsychotic. And if the patient reaches the ICU, we have to give them dantrolene and bromocriptine. But I've not seen AMC ask about these two things, but just keep in mind just to cover the topic completely. All right. Now in March 2026. And they had antipsychotic side effects chart. All right, and for a lot of them you need to ask about the EPS, haloperidol, flufenazine, and most metabolic is clozapine, olanzapine. Least EPS is quintiapine, clozapine, and aripiprazole. Clozapine is mandatory weekly, and we have to check FBE for these patients. All right, now acute dystonia from metoclopramide or antipsychotic. The treatment for this is going to be benztropine, which is an anticholinergic. We give that IV or IM. Most likely it will be IM because of the condition of the patient. But if it's IV or IM in your question, they'll either give you IV or IM. Just keep an eye on that because they could just write benztropine orally, which will not work. So you'll have to give them IM or IV because benztropine is going to reverse the acute EPS. And this was specifically asked in the February 2026 recalls. All right, metoclopramide for vomiting, migraine causing muscle contractions, and which means that it's extrapyramidal effect. Then digoxin toxicity management, we stop digoxin and correct electrolytes. All right, and the what do you call it, the antidote for it is it's either going to be digifab or there's something called digibind. All right, sorry, digibind. Right, so they'll ask you about these as well. So digibind is also an antidote for it, but it's not acute, it's for long term. All right, moving on to borderline personality disorder, which is BPD. All right, we have the definition is that they'll have a pervasive pattern of instability. It will be, there will be instability in interpersonal relationships, self-image, affect, and impulse control. Now moving on to the core features is that they'll have intense unstable relationships. So they will not be able to keep up with the relationships. A lot of breakups, divorces sometimes. Then there'll be identity disturbances, impulsivity such as spending their money or having extramarital affairs. A lot of them cheating on their partners. Then substance abuse. Now the main one for this is self-harm. This is very important to know. All right, so if you see a self-harm in the question, it's most likely going to be BPD. All right, but you have to take the whole picture, but self-harm is one of the key words they like to use for BPD. All right, then they'll have emotional dysregulation, chronic emptiness, intense anger, transient paranoid ideation or dissociation under stress. Now, how do you distinguish it from other disorders such as bipolar disorder? All right, episodic mood changes is in bipolar disorder, whereas in BPD we'll have chronic and reactive to interpersonal stress. Antisocial personality disorder, they'll have callousness, lack of remorse, versus BPT where they have intense emotions and self-harm. PTSD is trauma related, no trauma in the history. That means it's most likely going to be BPD. Now the treatment is going to be dialectical behavior therapy, DBT, which is gold standard for these patients. All right, and first line, and it's specifically developed for BPD. And if you see this in the answer, that's most likely going to be the answer to go for, the treatment to go for. All right, components, I've not seen them asked, but sometimes they do say that they'll list maybe 4 or 5 of the components and ask you the 5th one. All right, All right, pharmacotherapy, no medication is specifically approved for BPD, and we treat the comorbid conditions such as depression, SSRIs, psychotic feature. We have low dose antipsychotics, and we avoid benzodiazepines in BPD. All right, important because risk of addiction is there. All right, now the AMC key is going to be unstable emotions, but most importantly, self harm and unstable relationships, plus fear of abandonment. Most likely going to be BPD, and again, treatment is going to be DBT. All right, so BPD treatment is DBT, easy to remember. All right, now moving on to psychological defense mechanisms. The thing is that they'll give you that, you have a patient, the patient says this, and you tell this to the patient, and then the patient reacts that way. All right, so they'll ask you what type of defense mechanism is this patient giving you, right? So transference is that unconscious process where the patient is going to redirect their feelings from an important past relationship onto another person, and this can be positive, all right, or it's going to be negative sometimes. All right, so sometimes the patient is going to ask for a coffee with the therapist after discussing personal emotional history, and most likely this answer is going to be transference. Now counter transference is the other way around, that therapist's emotional reaction to the patient transfers from the therapist's own past. All right, so sometimes the therapist is going to feel excessively angry or attraction towards a patient. Sublimation, which is a mature defense mechanism, is that they take unacceptable impulses such as sexual or anger, and they're going to redirect into socially acceptable or productive activities. Now disinhibition, it is the reduction or loss of normal social restraints, so impulsive or inappropriate behavior, which is seen mostly in mania or frontal lobe damage, intoxication, or dementia, because sometimes the patient may become sexually inappropriate comments in the clinic, and usually it's going to be caused by mania, frontal lobe pathologies, or intoxication, and it is not a defense mechanism. All right, so moving on to projection. Projection is attributing one's unacceptable feelings to others. So the person who feels angry at the doctor accuses the doctor of being hostile. All right, now reaction formation, it is converting an unacceptable feeling into its opposite. So the person who with unconscious aggression towards a sibling becomes excessively caring for the sibling. Now displacement is redirecting the emotions from original source to a less threatening target. So the patient angry at the doctor shouts at the nursing staff instead. All right, now the AMC distinction that we need to make is transference, where it's patient to therapist based on past relationship, where compared to counter transference, where the therapist is having transference onto them. All right, so in transference we have the patient's reaction, whereas in counter transference we have the reaction of the therapist. All right, so you guys can read this, but it's pretty straightforward. And sublimation is more mature defense mechanism and always a positive outcome, whereas projection is a mature defense mechanism. All right, now moving on to something very important, which is postpartum mood spectrum, and most important part of it is the timings. All right, if I was you, I would memorize these timings, because a lot of the questions are going to be based on those timings itself. So if it's on day 2 to 5 from postpartum, it's most likely baby blues. All right, and it's going to resolve by day 10. If it doesn't resolve by day 10, then something's wrong. All right, features are going to be transient mood changes, anxiety, irritability, intact insight. So a patient has intact insight, so they know what's going on, and the patient recognizes thoughts are irrational, able to dismiss intrusive thoughts. They're, most important is that they're able to dismiss those intrusive thoughts. No functional impairment, and normal bonding with the baby. Now this is more important, because their bonding is how it's going to affect the growth of the baby and the outcome of their relationship with the family as well. So if they don't take proper bonding with the baby, or they don't take proper care of the baby, then most likely we would have to get child services sometimes involved as well. But if the mother is too overworked, instead of getting child services involved, we're going to offer them communal support, and offer them help with the upbringing and the taking care of their house chores as well as the baby. All right, now again, treatment is going to be reassurance, support, and because it's self-limiting, we monitor for progression, and then no pharmacotherapy is needed. All right, now moving on to PPD. It occurs 2 to 8 weeks postpartum and can be within 1 year. All right, it's persistent. Remember, this was transient. This is persistent. Low mood, and then functional impairment. They can't function properly, and they may have guilt, worthlessness, and it meets the MDD criteria. Then Edinburgh postnatal depression scale, EPDS, is more than 13. It's most likely going to be PPD. In this, we use pharmacotherapy. We give SSRIs and CBT sometimes, and we have a mother baby unit if the mother condition is pretty severe. Now, postpartum psychosis, it happens pretty quickly, so it's 72 hours to 2 weeks postpartum, and it's a rapid onset. Now, it's an emergency, remember, because the patient is confused, delusional. So they say, these are keywords: baby is evil, baby is an imposter, etc. And hallucinations, we have manic features, loss of insight. All right, this is an important point to differentiate between baby blues, because baby blues also occur within the 2 to 5 window, so 72 hours, 2 weeks, it could overlap. So if they have a loss of insight and bizarre behavior, severe agitation, risk of infanticide, this is very important. Right, what do we do with that? We have an inpatient admission. We have to get them into mother baby unit, antipsychotics, mood stabilizers, and we have to do ECT if it's needed. Right, now the difference between all of them is that baby blues is transient, mild, and inside is intact, and it's self-limiting. PPD is going to be persistent for more than 2 weeks, and there's functional impairment. EPDSO is going to be more than 13, and psychosis is going to be rapid onset, delusional hallucinations, loss of insight, and it's an emergency. All right, that's psychosis. Now, PTSD, the updated, the guideline for that says that these are what the patients may present with. And PTSD will have something known as the HARD mnemonic. All right, H is going to be hyperarousal, which is exaggerated startle response, hypervigilance, sleep disturbances, irritability. Now remember, for PTSD, patients should have a traumatic experience in the past. All right, then we have avoidance of trauma-associated stimuli, re-experiences. They have flashbacks, they have nightmares, they have dreams related to it. That suddenly wake up in the middle of the night. Then the stress duration is going to be more than 1 month, plus functional impairment. Now there are a few additional DSM-5 criteria for that, such as negative cognitions and moods, such as survivor's guilt, persistent negative beliefs, emotional numbing, anhedonia, loss of interest in activities. Now the EMCK is going to be trauma exposure plus re-experiencing plus avoidance plus hyperarousal, and duration, remember, duration is supposed to be more than 1 month. All right. Then the treatment for that is going to be trauma focused CBT, which is TFCBT or EMDR, and SSRIs can be used, but we always avoid benzodiazepines and PTSD. So PTSD, we don't give Ben. All right, no PTSD for Ben. All right. Now, gender incongruence, I've seen questions of this in February recall, and they ask you what do you do in this situation, or sometimes they just ask you to diagnose it. That's it. Our definition is going to be marked incongruence between assigned gender at birth and experience or expressed gender. Then when the adolescent is present, we do not prescribe hormones immediately, and we do not refuse support. Now, the correct approach is going to be assess the sexual congruency, comprehensive psychosocial and gender assessment, and we usually get a multidisciplinary team involved in this. Now, something that's very important for you to know is the Gillick competence. All right, not just for gender incongruence, but for also abortion in ladies around the age of 15 to 16. You have to get a Gillick competence score done. All right, because they may have the capacity to consent to treatment if they have sufficient maturity and understanding with no fixed age. All right, now parental consent typically also required for minors. All right, now treatment has different stages. So stage 1 is going to be puberty blockers. We have GnRH agonist to pause puberty, which is reversible. Then we have gender affirming hormones such as testosterone or estrogen, depending on what do they want. And stage 3, which is surgery, which is not before adulthood typically, because surgery is irreversible. All right, we have to assess sexual congruency. All right, and we do not immediately prescribe, and we do not refuse. Now, these are the key numbers. Go over it. It's very important for you to memorize. If the bare bone minimum, memorize these. If you guys want more notes, if you guys want more material that's up to date with therapeutic guidelines, join the Telegram group. If you have not registered or don't have a placement letter, you can just join the foundation group on Telegram. These both are completely free. And guys, it's very it's resources that you cannot find anywhere, and these are invaluable resources that me and my team have worked a lot on, and hopefully you guys can benefit from it for free as well. And if you guys want to see more videos, just subscribe, leave a comment, hit the like button, so that we know you guys are actually benefiting from these videos and you would like to see more of these. All right, have a good day.